and good evening, good afternoon, good morning, ladies and gentlemen, to whenever you are listening to this presentation. I am talking about allergic diseases, allergic disorders today, and there was also a pre-assignment that was attached to this. So, the class outcomes for today we are going to distinguish between the normal immune response and the abnormal physiological events seen with allergic reactions. We are going to differentiate between the abnormal assessments that are commonly seen in clients with an allergy history and a normal adult assessment, because if we know what is normal, then we are better to assess what is not within the norm or abnormal. We are going to judge the appropriateness and the safety of administering the more common medications that are going to be used for the treatment of hypersensitivity and hypersensitivity reactions. We will evaluate the needs of clients with allergies and or their families for education in order to prevent and manage anaphylaxis or an allergic reaction should it occur. Because if your client is in the throes of the reaction, they may not be able to administer treatment themselves. In the event of anaphylaxis, if they cannot use their EpiPen, then someone needs to know how to use the EpiPen on them, administer the epinephrine. So not only does the client need education, but whoever they live with, whoever they work with, whoever their partner is, perhaps the child, they need to know how to manage these reactions. And because we are nurses, we are going to formulate a plan of care for health restoration for a patient experiencing a hypersensitivity response, because a lot of this is client driven. They need to know themselves, they need to know their triggers, they need to be self aware of what they are sensitive to. So, just some definitions here about terms that we're going to use when we're talking about these disorders. An allergy. An allergy is simply a hypersensitivity reaction that is initiated by an immunological mechanism. This means that I have come into contact with something that my body is viewing as a foreign body, something that is not part of me, and there is going to be an immune response. An allergen, an allergen is an antigen that is going to cause the allergy. Then antibodies. Antibodies are large Y-shaped proteins that are used by the immune system to identify and neutralize pathogens such as bacteria and viruses. And we know this, right, because the immune system, is what we use to fight off infections, right? Viruses are infections, and then we have bacterial infections. If we can no longer fight off a bacterial infection on our own, then what happens is that we need an antibiotic, right? We need a little bit of help to kill that bacteria. But a virus, we have to battle the virus on our own, and we are seeing now this, especially in these times, in this last year when we are talking about the pandemic and we are talking about COVID. An antigen is any substance that will cause the immune system to produce antibodies against it. So this is what we're doing when we are taking the vaccine. Atopy refers to personal and or familial tendency. This means that a disorder or an allergic reaction will travel in families. It will live in families. For example, if one of your parents is lactose intolerant, then there is a very good chance that you may be lactose intolerant. If somebody is allergic to gluten or wheat, there is a very good chance that you may be also, or there may be other members of your family that have this same sensitivity. So it is a personal and or familial tendency to become sensitized and produce antibodies in response to ordinary exposure to allergens. So, as a consequence, such individuals can develop typical symptoms of asthma, rhinitis, or eczema. And then a hypersensitivity. This will cause objectively reproducible signs or symptoms initiated by exposure to a defined stimulus that is tolerated by normal subjects. So what this simply means is that um, I have cats, and when I am in my home with my cats have the run of the home. So when I am in my home and my cats are, on my blankets or on my couch, I am quite fine with it. I have a friend though that is sensitive to cats, and so when she comes in, sometimes her eyes will get a little itchy, her throat might get a little sore, and this is because she is sensitive. She has a hypersensitivity to my cats. Asthma. Although we always refer to asthma as a respiratory disorder, it is not. It is more of an allergic disorder. It is a chronic inflammatory disorder of the airways. This simply means that I have come into contact with something that I am sensitive to. So in susceptible individuals, this inflammation causes recurrent episodes of wheezing, breathlessness, chest tightness, and cough periodically at night or in the early morning. But this can also happen, this is for somebody who is diagnosed with asthma, but this can also happen with someone who, for instance, may have exercise-induced asthma. So this means that after I overwork myself, or if I work myself a little too hard, I'm playing basketball for a little too long, or if I'm going for an extended run, or if I rode my bike a little further today, that I am going to get this inflammatory response of wheezing and feel breathless. And then rhinitis. Rhinitis is when symptoms of an immunologically mediated hypersensitivity reaction in the nose and conjunctiva. So this means that I have itchy eyes, I have an itchy throat because I have come into contact with something that I am sensitive to, that I may be allergic to. Dermatitis. Dermatitis is an umbrella term for a local inflammation of the skin. IgE antibodies. We are going to talk about these an awful lot when we are talking about these allergic disorders. And they are antibodies that will travel to cells that release chemicals, causing this allergic reaction. So, the primary immune dysfunction, and then we are going to talk about B cell deficiencies. So, primary immune dysfunction will involve a B cell deficiency. And B cells are involved in producing a humoral response, an antibody response. An antibody or an immunoglobulin is produced in response to a foreign substance known as an antigen. So remember, the antigen is going to be the trigger, right? So now there's something that my body is seeing as foreign. It doesn't like it, and so it is going to produce an antibody to fight off this foreign substance. So B cell deficiencies will involve a lack of differentiation of B cell precursors into mature B cells, or from a lack of differentiation of B cells into plasma cell. And an example of a B cell deficiency is what we call an X-linked amiglobulinemia, XLA. So this can be either inherited or congenital, a primary immune deficiency. So it is It comes from a parent, it can come from a parent, and it is present at birth. The term X-linked recessive means that the gene that causes this disease is located on the X chromosome. So now we know from A and P, think back, that females will have two X chromosomes and the males will have an X and a Y. That is why the males will determine the sex of the child. So X-linked gamma globulinemia primarily affects males because it is unlikely that females will inherit two X chromosomes, which will carry the altered gene. So as males get only one X chromosome, if their one X chromosome carries an altered or disease-carrying gene, then they will have symptoms of this disease. So the pathophysiology. X-linked gamma globulinemia, also known as Burton's gamma globulinemia, is the result of a mutation of the BTK gene. This gene is present on the long arm of the X chromosome, and its defect results in deficiency of Bruton's tyrosine kinase, which is essential for the development of the B lymphocyte. So, B cells are specialized white blood cells, WBCs, that when mature will produce special proteins called antibodies or the immunoglobulins. So, and in just a moment, all of this is going to make sense to you. So the BTK protein will transmit chemicals that will alert the B cells to mature and then produce antibodies. This is the first type of B cell deficiency in which immature B cells are present in normal numbers, but they are unable to mature. So, so when someone has this disorder or this, or they carry this gene, it means that their B cells, which are going to help immature white blood cells mature, is not present. So, with that being said, this tells me that this is going to have to do with my immune system, that I may not be able to fight off everything that everybody else may be able to fight off. So for me, there will be a greater risk for some types of infections. So clinical manifestations. Clinical manifestations of this disease will include infections of the ears, the lungs, the skin, the conjunctiva, and then the central nervous system. So chronic respiratory infections such as sinus infections and pulmonary disease are common clinical manifestations. Clients will have recurrent pneumonia, meningitis, and septicemia with organisms such as Streptococcus pneumoniae and Haemophilus influenzae. So again, this tells me that I am going to have difficulty if I have this disorder fighting off infections. So medical management, how is this disorder diagnosed? Well, diagnostics will include B lymphocyte surface marker assays, which will identify specific cells that are involved in the immune response. These are general tests that can aid in the diagnosis of primary immunodeficiency disorders. Again, there's a problem with my immune response. They will diagnose disorders by identifying abnormal numbers and percentages of B lymphocytes and help to evaluate immunodeficiencies. So in X-linked gamma globulinemia, XLA, blood tests will indicate a lack of circulating B cells as well as low levels of immunoglobulins. So women with a family member with XLA should seek genetic counseling because, again, this is something that is atopic, meaning that it will travel in families. Treatment. So what are we going to do for these clients? Treatment will include giving IV immunoglobulin, IVIG, to provide short-term passive immunity. IV immunoglobulin is a sterilized solution made from human plasma. It will contain the antibodies, mostly immunoglobulin G, which is the IgG, or gamma globulin, to help protect against infection from various diseases. So the dosage and the schedule are going to be individualized, but typically IV immunoglobulin is given every 3 to 4 weeks. And if you can, think about this as a little booster to the client's immune system. So because it is immature, because they cannot fight off infections, because they are at risk for infection, what this will do is this is going to boost their immune system and hopefully give them a better chance to either fight an infection or prevent infection. So, gamma globulin can also be given by weekly subcutaneous injections. So this tells me that the client may be able to be taught this, how to give these injections, or if needed, a family member can be educated on how to give these injections. Both routes will provide therapeutic concentrations of serum IgG, and patients may also take a low dose of prophylactic antibodies regularly, even when feeling well, if the episodes of infection are frequent. And now I know that there are two schools of thought out there about antibiotics. There are many physicians who believe that they will not give an antibiotic unless it's absolutely positively necessary. They have a specific criteria that they like to meet because there are many people out there that are resistant to antibiotics. And so it's very difficult when they become sick to find an antibiotic that will help them. And then there are these physicians who understand that someone with this disease, their immune system is going to need a little help, so they will give them a low dose of an antibiotic in addition to the serum IgG or the serum IVIG, so that they can prevent infection and feel well, or have an easier time if they do become infected with something. And so the aim of prophylactic antibodies is to prevent an infection from starting, because they have such a difficult time in battling it. So nursing management, and because we are nurses, we are going to assess and then we reassess, and if necessary, we're going to go back and assess a third time. So many of the clinical manifestations that are observed in the client with XLA are directly related to infection of the respiratory tract, the skin, the conjunctiva, the ears. So common findings will include overall generalized, they will have a fever. There may be changes in their behavior. There may be changes in their eating patterns. They may become more irritable. They may have a little bit of malaise. There may be some decreased activity. There will be changes in their behavior. Respiratory-wise, they may have an increased respiratory rate. They may have absent or decreased lung sounds. They may have a rash. They may have noticeable lesions. Their eyes may be a little reddened. They may have some drainage. Nursing diagnosis. Nursing diagnosis for this population is risk for infection. Listen up, ladies and gentlemen. Listen up, and then listen up one more time. A nursing diagnosis for this population is risk for infection related to compromised host defenses secondary to B cell immunodeficiency. This population is at risk for infection because their B cells cannot contribute to maturing their WBCs and battling an infection. Nursing interventions. Well, we are going to assess and then reassess. We are going to look at vital signs, Increased temperature may indicate the presence of an infection. Respiratory rates may increase with respiratory infections in an effort to increase oxygenation. So we are looking at vital signs. And we are going to assess lung sounds. Decreased or absent breath sounds or adventitious breath sounds may be present with excessive secretions that are common with respiratory infections. We are going to look at the eyes, we're going to look at the ears, we're going to look at the skin, the nails. We are looking for rashes, we are looking for lesions. Red, inflamed ears will indicate an ear infection. Red conjunctiva with drainage will indicate conjunctivitis, which is a common manifestation. So what are we going to do? Some nursing actions will be to administer IV gamma globulin as ordered, administer prophylactic antibiotic therapy as ordered, and we will anticipate prompt treatment with antibiotics if an infection becomes present. So patient education, again, because this is something that is going to be lifelong, a lot of patient education is intended. We are going to educate on precautions to prevent infection and minimize any source of infection in the environment at home related to foods, particularly raw foods, because that's going to put them at a risk. Domestic animals, many people have a sensitivity to animal dander. Or unsanitary conditions. Where are they living? What are the conditions in the home? Additionally, sites that accumulate stagnant water, such as sinks, toilets, waste pipes, cleaning tools, face cloths, readily support microbial growth and can become secondary reservoirs of infection. So we need to teach them how to be cognizant at home, how to make sure that their home environment is not exactly sterile, because I don't think that ever happens. I raised 2 children. But it has to be clean. It has to be able to maintain so that they remain as free of infection while being at home as possible. And then we are going to instruct the client to protect themselves from any direct contact with anyone with a contagious illness. And of course, especially now in these times where everyone is wearing a mask and social distancing and social isolation, this really should be the norm right now. But again, we need to remind them that if there is someone that is not feeling well, that they should not have contact with that person, or if they may not be feeling well, that they not have contact with anyone else, so that they will not contract a secondary infection. We are going to talk to them about safe food handling and storage practices. We are going to educate that signs and symptoms of infection and when to seek medical attention, particularly if they begin to develop a temperature of 100.5 or more, because fever will be the first sign of infection. We are going to instruct them on good hand washing, which of course everyone is doing right now. And we are going to direct them, because this is lifelong and because it's atopic, something that lives in families and something that they could pass on to their children. We are going to support them with information regarding genetic disorders, and we are going to make available to them information about community support groups, so that because living like this, it can be a little depressing, because it can be a little self-isolating. So support groups with others that are going through this and the things that they have discovered to make their life easier. Sometimes there is just comfort in being able to share. So how do I know? How do I know that I've done a good job in taking care of this client that has XLA? Well, appropriate antibiotic therapy and treatment with IVIG can help clients with XLA lead normal, active lives. And this is what they need to know, that they can lead normal, active lives. The family and the client should be provided with information regarding the importance of preventing infection and also when to contact their health care provider. And most clients can have a very good prognosis if they start the antibody replacement early. So, to move on to allergic reactions, the actual allergic reaction. When the immune system starts fighting substances that are usually harmless, such as dust mites, pollen, foods, medicines, as though these substances were trying to attack the body. This overreaction to this substance, which is usually harmless, but for this individual is not, this overreaction can cause a rash, itchy eyes, runny nose, nausea, diarrhea, or some respiratory distress. So these are the steps in an allergic reaction. The first exposure to an allergen will result in formation of these IgE antibodies, which will attach, attach to mast cells. And so with this mast cell, this is when histamine is released. So in order to stop the reaction at this time, in this time frame, we need to take what? We need to take an antihistamine because that is going to stop the mast cells from releasing the histamine, and then that will help to resolve the symptoms. So in the second exposure, this will cause the allergen to bind to the IgE antibodies that are attached to the mast cells, causing degranulation and then release of histamine and then other chemicals. So again, we can take an antihistamine again to resolve these symptoms. So the primary chemical mediators are histamine, leukotrienes, the platelet activating factor, and then the prostaglandins. So histamine is the primary chemical mediator that is released by the mast cells. This will cause contraction of the bronchial smooth muscles. It will cause dilation of small vessels and constriction of the larger vessels. So we end up with some edema, some redness. We can have urticaria, which is another fancy name for hives. And this will cause an increase in the secretions of the gastric and the mucosal cells, causing your client to have diarrhea. So the leukotrienes enhance the effect of histamine on the smooth muscle of the bronchi and increase vascular permeability. So what the leukotrienes do is they help the allergic reaction to move along. They will intensify this allergic response. So your client will now begin to experience maybe some wheezing and some bronchial constriction. So their chest might start to feel a little tight. They might be able to get a little breathless. The platelet activating factor, this is released by the leukocytes. It initiates platelet aggregation, and this also causes bronchoconstriction. So again, your client's chest is going to feel a little tighter. It is going to be a little more difficult for them to breathe, to take a deep breath. They will be short of breath. The platelet activating factor increases vascular permeability. So now your client will begin to experience systemic hypotension and an increase in pulmonary artery pressure. The prostaglandins. The prostaglandins produce a smooth muscle contraction. It causes vasodilation. again, increases vascular permeability. So your client will remain with symptoms of bronchial constriction, but now they have moved into a wheeze. And we've all heard wheezes. Maybe no, maybe you haven't heard wheezes yet. But when you are listening to a chest and there is that musical sound, that wheeze, um, that is one of the most dangerous sounds that you can hear in someone's lung field. It means that they are on their way to a quiet chest, which is deadly. So you will hear this with the prostaglandin release, and they may also have some edema, some periorbital edema, and some nausea and vomiting. So, a normal antigen-antibody reaction. So, in a normal reaction where someone is not allergic to anything, or they come into something that, they do not have a sensitivity to, the lymphocytes will respond to the antigen. The invader, whatever it is rendered harmless. It is destroyed, and we move on. In an allergic response where there is an abnormal antigen-antibody reaction, this is when the mast cells are stimulated by the antigen. So we come into contact with something that we are sensitive to or allergic to, and then these mast cells are activated. They are releasing histamine. So the immune system will respond aggressively with an outpouring of the chemical mediators, beginning with the histamine. Chemical mediators will then produce symptoms ranging from mild, which is urticaria, which is again a fancy name for hives, or life-threatening anaphylaxis. So the more these chemical mediators are outpoured, the more and more and the further we get into this reaction will determine how severe the reaction is for your client. So the types of hypersensitivity disorders. The type 1 is an allergic anaphylaxis and then atopy. Type 2 is an antibody reaction. Type 3 is an immune complex. And then type 4 is a delayed reaction. So the mnemonic is A, B, C, and D. In a type 1 hypersensitivity disorder, there can be anaphylaxis. However, allergic rhinitis, ladies and gentlemen, listen up, and then listen up one more time. Allergic rhinitis is a type 1 hypersensitivity disorder. Atopic dermatitis, urticaria hives, and then angioedema are all type 1 hypersensitivity disorders as well. So GI allergies, asthma, and the very popular latex allergies are also considered hypersensitivity disorders. So in a type 1 hypersensitivity disorder, that will result in allergic disease, atopic disease. Remember when we were talking about atopy, we say that it is familial, it will travel in families. So it is an allergic disorder that has a genetic predisposition, and it will affect 10 to 20% of the population. Some clinical manifestations of these hypersensitivity reactions. If it is a mild hypersensitivity reaction, the onset of symptoms will begin within 2 hours. Your client can have some peripheral tingling in the fingers. There can be a fullness in the throat, in the mouth. Their tongue might feel a little thick. They can have some nasal congestion, some periorbital swelling, itchy skin, itchy eyes. Moving on to a moderate hypersensitivity reaction. Again, the onset of symptoms will be within 2 hours. They will still have the peripheral tingling and the warmth in their fingers or toes. They will have the fullness in their throat and in their mouth. They will remain with the nasal congestion, the periorbital swelling, the itching, but they will have progressed to anxiety, bronchospasm, and then now edema of the airways. So now this is where we are going into the bronchial constriction. If it is a severe reaction, we will see bronchospasm, we will see laryngeal edema. They will be severely short of breath, have much difficulty breathing, and they may be cyanotic. They may have abdominal cramping, they may have vomiting, they may have diarrhea, they may progress to seizures, and then finally, they may progress to cardiac arrest or coma. So, some clinical manifestations of anaphylaxis. Anaphylaxis is a clinical response to an immediate immunological reaction between a specific antigen and an antibody. So this reaction will result from the IgE antibody and then other chemical mediators. It is immediate. Listen up, ladies and gentlemen, listen up, and please listen up one more time. When we are talking about anaphylaxis, it is immediate, it is life-threatening, and there has always been a prior exposure. No one will have an anaphylactic reaction to something on the first exposure. There is always a prior exposure. So with the prior exposure, it may have been itchy eyes, a sore throat, fullness in the throat, their tongue might have gotten a little thick, and then they might have taken some medications, and then that has gone away. But now with the second exposure, they are going into full anaphylaxis. So allergic disorders type 1 and type 4 hypersensitivity disorders are the only two hypersensitivity disorders that are considered allergic disorders. So type 1 and type 4. So for allergic diseases include hay fever, food allergies, atopic dermatitis, allergic asthma, and then finally anaphylaxis. So how do we diagnose? Well, when we are looking at diagnosing, we always start at the same place, and that is with a complete health history. We are always going to start with talking to our client to diagnose this. So we are going to do a complete allergy history. We are talking to patients. We are talking to their family members because we know some of these disorders will travel in families. So it stands to reason that we want to talk to the family because we want to know who else has these sensitivities. So family history of allergies, client history of allergies, do they have asthma? Does anyone in the family have asthma? Has there been a prior history of anaphylaxis either with your client or with a family member? And have they undergone previous antibiotic therapy? Because previous antibiotic therapy can also be a precursor to an allergic disorder. What was their degree of difficulty? How uncomfortable were they? And how frequently do they have these allergic symptoms? So then the degree and circumstance of improvement. So if they were sensitive to something in the detergent, did they change the detergent? Changes in weather, changes of season. Some people have allergies in spring, some are in fall. Do they stay inside? Do they keep their windows closed? Do they just, take Claritin and suffer through it? What do they do? And if it is a food allergy, do they just stay away from that certain food? So with diagnosis, sometimes comes lab studies. So we will do a CBC with a differential, and we are going to look at the eosinophil count. If this is an increased level, then we know that this has been an active allergic response. we are looking at serum IgE levels. This will differentiate between allergic disease from other causes. Example, viral rhinitis versus allergic rhinitis. So if it is viral, then the IgE level will be increased. If it is allergic rhinitis, it will not. And then we are going to look at the RAST, the radioallergosorbent test. And this is the individual serum is exposed directly to the antigen. Skin tests. Skin tests will rule out the antigen or the antigens that are involved. There is the prick, the scratch, and the intradermal. It is provocative. There is direct exposure to the antigen. It is very definitive. So this is always done with a physician present because depending on how severe the reaction was, when we are again exposing them to this antigen, the reaction could be very severe because remember, if with a prior exposure, there is always the risk of anaphylaxis. And this is never performed during an acute episode, So the less challenging testing should be done first, and then there is always emergency equipment necessary because, again, with prior exposure, there is the risk of anaphylaxis. So when we are interpreting or when doctor is interpreting these results, it is a grading system and it is always clinically driven. So some of the medications that were contraindicated during this skin testing, right, because these are medications that we don't want them to take because it's not going to give us an accurate result. They need to stop their antihistamines. Remember, because if they're taking an antihistamine routinely, say they have allergic rhinitis, and they're taking an antihistamine daily because we want to stop that reaction from the mast cells, well, they have to discontinue the antihistamine 5 to 7 days before testing so that the information is accurate. Antidepressants, anti-anxiety medications, and psychiatric medications are discontinued 48 hours before testing. If they are on an H2 blocker, which is also considered an antagonist, they will discontinue that 48 hours before testing. Beta blockers are discontinued 24 hours before test. So again, diagnosis. So we've done the health history. We've talked to the client. We've talked to the family. We've gone as far as we can go. We've looked at some lab studies. We may or may not have done the skin testing. And now we are going to do the physical exam. So when we're looking at the nose and the mouth, the mucous membranes, they may be swollen, they may be pale, they may be bluish because remember, with vasoconstriction, there may be some cyanosis. Their eyes, they may be red. There may be some drainage. They may tell you that they're itchy. Their throat is going to be swollen. Their voice is going to be hoarse. They may be hearing impaired at the time of the event because the tympanic membrane may be swollen. Their sinuses, those membranes are going to be swollen, so they're going to have that nasal congestion. They may not be able to smell very well. When we're listening to the lung sounds, there may be wheezing, that very, very dangerous sound. They may have a cough. We may see that they're short of breath. They may have increased respirations leading to respiratory arrest. Neurologically, they may complain of a headache. They may be dizzy. They may have paresthesia, that tingling in their fingers or in their toes. They may also have a feeling of impending doom. Now, traditionally, I will tell you that when you are talking with a client and they say, oh my gosh, something bad is going to happen, I get the feeling something bad is going to happen, Not that you want to dismiss it, because you never want to dismiss anything that a client is saying. But traditionally, my thought is, if you can tell me um, that something bad is going to happen, um, not that I will dismiss it, but traditionally, some of it is anxiety. Something bad's going to happen. Here, in these clients, when they are telling you that something bad is going to happen, they are feeling like they're dying, this population, this client here, you believe. Because when there is a feeling of impending doom for this population, it is true. They are definitely feeling of impending doom, and they know that they are circling the drain and something bad is going to happen. They can have pruritus, which is a fancy word for itching. The angioedema, you will see swollen orbits around the eyes. There may be erythema. They may have areas of redness, and they may have the urticaria, which are hives. Cardiovascular, they are hypotensive. There may be cardiac arrhythmias, tachycardia. Their heart rate may be increased, and all of this will lead them to cardiac arrest, which again, they will, before this happens, they will verbalize that feeling of impending doom. GI-wise, they will have abdominal cramping, they may have pain, and they may have nausea, vomiting, diarrhea. So medical management. How are we going to stop this, or how are we going to prevent it from happening in the future? We are going to give them lots of education, and one of the things that we are going to educate them on is the EpiPen. But not only are we going to give them education on the EpiPen, anybody that they live with, anybody that they go to school with, anybody that they work with will also be educated on the EpiPen, because if they are in the throes of a reaction and they cannot get to the EpiPen, or they cannot use the EpiPen themselves, someone needs to use the EpiPen on them. Someone needs to administer that EpiPen. And then we're going to talk to them about patient education, about avoiding their triggers. They need to know their triggers, avoid the triggers, how to manage those triggers. And then we need to tell them how to treat the reaction, and we are going to tell them that this treatment will depend, of course, on the symptoms, mild versus moderate versus severe. So medical management, epinephrine, it can be either subcutaneous, as in with the EpiPen, IV push, can be IV infusion, or if absolutely necessary and in the throes of anaphylaxis, it can be given via an endotracheal tube, which is an ET tube. This will increase the heart rate, so it will increase cardiac output. It will cause vasoconstriction, so it will increase their BP. It will reverse the bronchoconstriction, and it will suppress the inflammation. Then we will follow that with a corticosteroid, and this can be given IV push and IV infusion. So antihistamines, we can give Benadryl IV push or IV piggyback. This will reduce the effect of the histamine. It will stop that histamine reaction. It will reduce the dilation of the small vessels and the constriction of the large vessels. It will reduce the increase in the secretions in the gastric and the mucosal cells, so it will reduce the abdominal cramping and the diarrhea. And then vasopressors, this will cause vasoconstriction, and this will maintain their blood pressure and their cardiac output. So nursing interventions, what are we going to do? We are going to maintain that patent airway. We are going to monitor the airway. We are going to monitor their O2 status. We are going to monitor that pulse ox. We are going to make sure that they have an IV access in case we have to give them IV medications. We are going to give them medications and IV fluids as doctor orders. We are going to look at lab studies. They are going to be on intake and output, and because of their severity of their reaction, they may have a urinary catheter, they may have a Foley catheter, and not at this time, but after the reaction has subsided and they are stable and ready for discharge, we are going to give them lots of patient education and family members as well. So, one of the times, the more common time that you will see a reaction, an allergic reaction in a hospital setting, is when we are giving a blood transfusion. So, blood transfusions and hemolytic transfusion reactions can be fatal. So, it is very important that these clients receive only matching blood types. So, and there are many things that we can do in an emergency setting to deal with these reactions. On table 20.8, on page 386 in your textbook, there is a box that will talk about transfusion reactions and hemolytic reactions. Please know that information. Listen up, and then listen up one more time. Please know the information on the box, on the table, on page 386. So now, allergic rhinitis. Allergic rhinitis is a type 1 hypersensitivity reaction. Symptoms will be very similar to viral rhinitis, but it will be more persistent and it will have a seasonal pattern because, again, this is attached to changes in the season. It's attached to the weather. Some people experience allergic rhinitis in the spring, some people in the fall. Histamine is the major mediator. There will be nasal congestion, a clear watery discharge. There will be itching of the nasal area, so they will have itchy nose, itchy eyes, itchy throat. They may experience a dry cough. So for medical treatment, histamines are going to be ordered. H1 receptor antagonists. Listen up, listen up, listen up, and listen up one more time. The action of the antihistamine is to discourage the release of this histamine. It is going to block the action of the histamine. And that only makes sense, right? Antihistamine, I am blocking the histamine release. So, for antihistamines, first generation antihistamines are very sedating, such as Benadryl. The less sedating are the second generation, and this is the Claritin, the Clarinex, the Allegra, the Zyrtex. All of these can be taken during the day, right? And many of you have taken them, or many of you know people who take these, but you know, the Benadryl is usually used at nighttime for sleeping. So we are going to maintain hydration and then optimum health practices. And again, this comes with self-awareness. Like, I know what I'm allergic to and I'm going to stay away from it. So they need to avoid or reduce the exposure to their allergens. Listen up, listen up, listen up one more time. Part of their medical treatment is to be educated and then to avoid or reduce their exposure to these allergens. There can be some adrenergic agents. Usually these are nasal sprays. They are topical vasoconstrictors that they can use. There are mast cell stabilizers, and these are also nasal sprays. Then there are corticosteroids. Some come in nasal sprays. Some are oral. Again, lots of patient education to help identify and avoid these triggers. Listen up, and listen up one more time. These clients will need patient education to help them identify and avoid those triggers. They need to be made self-aware. They will administer medications. We will administer them. We will teach them about administering their medications as doctor has ordered. And then patient education regarding follow-up. They need to come back. They need to be monitored. And then they need to be educated on the risk that they will have for anaphylaxis when they are allergic to an antigen. So, contact dermatitis. Contact dermatitis is a type 4 hypersensitivity disorder, and there is a delayed reaction with a type 4 hypersensitivity disorder. So, there will be an inflammatory reaction to the skin to an antigen. So, we either touch something, come in contact with something, rub up against something, and then it might take a bit of time, and then we're going to get home and we're going to realize, oh my gosh, I have a rash. And almost any substance can cause contact dermatitis. So some of the clinical manifestations your client will exhibit are red, hive-like papules and plaques with occasional vesicles, and these are red hives that become blistered. The exposed areas are more common, and that is because there is a relationship between the causative agent and the dermatitis, meaning that I am going to experience this redness or these hives where I have come in contact to whatever it is that I'm reacting to. So, what is the treatment? Well, of course, the treatment is to avoid that antigen, right? So, again, self awareness. We can take some antihistamines to stop the histamine reaction and block the reaction from going any further. And steroids, because we know that steroids will decrease inflammation. It will help with the itching. It will stop the reaction as well. So for skincare, we are going to give them patient education, encouraging cleansing with warm water and using a mild soap because we don't want to aggravate the area any further. Gentle drying, and if it is possible, to leave it open to the air to heal. And they will have patient education regarding topical medications because whenever we give our client a medication, we need to give them education. We will allow the patient to verbalize their feelings regarding their skin condition because, again, remember, if they are, if it's summertime and if they're out in a field or if they're out walking, hiking in the woods, and they come in contact with poison ivy, for example. But because, it's summertime and maybe they weren't prepared, and so the poison ivy is all over their legs, it might be on their arms, if they touch their neck or their face, um, you know, while they are healing from this, that we need to allow them time to verbalize, oh my gosh, this is what happens, and oh my gosh, I look awful, and they need to be able to talk about this. And then patient education regarding signs and symptoms of infection, because especially once these papules and these vesicles open, there is a break in the skin, which will put them at risk for infection. And then anaphylaxis. Anaphylaxis, as we have learned, is a systemic response. It is immediate. It is an immediate response to an allergen. Clinical manifestations will be shortness of breath. They will have those audible wheezes. They may have some crackles. They may have a skin reaction. The rash may appear. They will have nausea, vomiting, and or diarrhea. They may have angioedema, which is swelling just below the surface of the skin, typically around the mouth and the eyes. They are going to have anxiety. They're going to feel hot. They're going to be flushed. And if the anaphylaxis is severe, they will have bronchospasm. Their voice will be hoarse because their throat is closing. They will be hypotensive. One of the hallmark signs of anaphylaxis is this hypotension and tachycardia, because they are what? When we think about hypotension and tachycardia, we think shock, and your client is now beginning to circle the drain. There are many things that will cause your client to go into anaphylaxis. Some may be drugs, penicillin allergies, sulfa allergies. They may be allergic to tetracycline, chemotherapy agents, NSAIDs, aspirins, the cephalosporins. If they are allergic to insect venom, it may be a wasp, a hornet, a yellow jacket, a bee, those larger ants, those red ants that are horrific. At, I think they're in the spring or summer when they bite you. The ant bites are incredibly infectious and allergic. They may have a food allergy. Common are eggs, nuts, shellfish, chocolate, milk, fish, and strawberries, or any kind of berry. So animal serum, um, tetanus, diphtheria, antitoxins, rabies, and if you're a hiker, I guess snake venom. So medical management, what are we going to do? We are going to treat with epinephrine. Epinephrine is, listen up, listen up, listen up, and then listen up one more time. Epinephrine is a bronchodilator. It is a vasoconstrictor, and it will improve cardiac contractions. When your client is in the throes of anaphylaxis, intubation and CPR may be necessary. So, nursing interventions, what are we going to do? We are going to assess and then we're going to reassess because we are nurses. We are going to monitor vital signs and we are going to do a systems assessment. We are going to administer oxygen. We are going to elevate the head of the bed if they are not hypotensive. If they are hypotensive, we are going to leave them flat. We are giving them medications as doctor ordered. We are going to stay with the patient. This is not a patient that you will leave. You will stay at the bedside with this client. Someone else will go out and they will stay with the family to offer support. But if you are the primary nurse, you do not leave this patient. When all is said and done and the client has recovered, we are going to give them patient education regarding the agent, how to avoid contact in the future, because we do not want this to happen again. Because remember, if it happened once, it can happen again. So if they have experienced anaphylaxis once, they are at risk to have anaphylaxis again. We are going to educate the patient regarding signs and symptoms of the initial contact, the rash, the itching. This is the beginning of the reaction. You need to do something now to stop the reaction, whether it's an antihistamine or whether it's the EpiPen. And patient education regarding the use of the EpiPen. This EpiPen should always be with them. If your client has ever experienced an allergic reaction that has led to anaphylaxis, this EpiPen should always be with them, always, at all times. And we will educate the client regarding a medic alert bracelet. So, if a client calls the nurse in the emergency department and states that he was just stung by a bee while gardening, the client is afraid of a severe reaction because his neighbor had a severe reaction a week ago. Which nursing actions should the client take? We can advise the client to soak the site in hydrogen peroxide. We can ask the client if he ever sustained a bee sting in the past. Tell the client to call an ambulance for transport to the emergency department. Or tell the client not to worry about the bee sting unless difficulty breathing occurs. And so we will review the answer to this question when we meet in class time.